Hi guys, so we are back and this time we are discussing September paper 2, that is mock 13, question numbers 5, 6 and 7. So let's see how to solve these. So question number 5, we have already discussed question 1 to 4 in the previous mock and I have shared the link with all the enrolled candidates. Please go through the explanations. The good thing about online recording is if you're confused with a certain question or find a similar question that is confusing, you can always go back to the recording and listen to the explanation. And I hope explanation gets you more clarity. If any doubts, please leave me a WhatsApp message, okay? So SBQ5, a 50-year-old gentleman requested an implant to replace tooth 1-4. This is a universal tooth numbering system. So 1-4 becomes tooth number 2-6. Yeah. Which was extracted few months ago. He gives a history of profuse bleeding during his extraction, surgical extraction. He was on anticoagulant and calcium channel blocker for hypertension and consumes alcohol on weekends. Now see, 2-6 is a relatively simple tooth, but it can become complicated if there is some sinus involvement or there was too much infection. Also, the patient states that he was on anticoagulant. Now, normally we do extraction only if the INR ratio is between 2 to 3. In which scenario, so much of bleeding does not happen, the profuse bleeding does not happen. But since the patient is saying that, some complication may have happened. So you need to be very vigilant about such patients and you need to ask them a thorough history. So let's see what questions are asked. Extraction done before and patient came to you with the buccal plate is completely fractured. You say this is the reason there was profuse bleeding because the buccal plate was completely fractured. So how are you going to place the implant now? Now, what you can do is either you can put implant buccally or lingually or place a bone graft and wait. Now, if you put an implant buccally, how will you do that? Because the buccal plate is fractured. Place implant lingually means palatally. Oh no, the entire line of occlusion would be disturbed. So the best thing is to place a bone graft and wait. That should be your right answer of choice. Simple and clear, right? Second question. Before putting implant, you decided to put a bone graft. Okay. What question is the most relevant and important to ask? Now, history of alcohol. The patient has already given a history that he consumes alcohol on weekends. So you don't have to ask about it. Plus, what is the question? What is the most relevant, important to ask? Most relevant. You remember whenever I say most, best, initial, it means all the options are going to be correct. But you have to select that one single option which is the most important. Understood? So history of alcohol is correct, but then the question has already mentioned it, so I won't be choosing that as an answer. History of bone graft rejection. We have not, neither the question mentions that the patient had any previous implant or a bone graft. And it can be a relevant question, but it would be very low on my priority list of questions. History of metabolic diseases, well, he has hypertension and that has been mentioned. Though you can also ask history of diabetes, but then again that would be very low on my chart because even if the patient has diabetes, if it's controlled, it can be managed. But history of smoking, among the given options, very important because why? It has not been asked or given in the exam. So you need to ask because if the patient says he's a chronic smoker or a continuous smoker, then that's going to complicate your treatment because smoking is a significant risk factor for failure of implants. Understood? So that becomes my answer of choice because that is my most relevant question. I have a detailed explanation given, so please go through that. Which radiograph you will use for complete treatment planning of implant placement? Well, I'm sure even if you're a general dentist and practicing basic dentistry and never done implants, but if you're consulting somebody from implants, you always say get a CBCT done, correct? So given in the list of the choice, I would go with CBCT. Of course, we do a first periapical and then we take an OPG, but ultimately we go with CBCT. So if that is given, that should be your answer of choice. Now, see, this question can be asked in one more scenario that you are in a rural area and what is the initial radiograph that you would be taking? And if the option has been given as OPG, then that would be your option of choice. Or if the question asked you are in your clinical practice and the patient has come first time to you, and what would be the initial x-ray that you would take? Again, OPG would be your answer. But if the same question asked which would be the best radiograph that you should be recommending to the patient, then it would be CBCT. Understood? If not, go back to the recording and listen again. Okay? So these are the various scenarios that can be asked. The implant failure rate for smokers is, now this you have to mug up. It's 11%. Even I wouldn't know. Somebody has done the stats and they have come down with this figure. So it's 11%. Now you need to assess the quality and quantity of the bone for implant placement. Which factor will determine your radiographic technique? Okay. So when I'm going to place an implant, I want to determine the quality and quantity of the bone. So when we say bone, we are looking for anatomical landmarks, some vital structures, the clarity of the image which will show us that which relevant structures are nearby the implant. For example, if the bone is very less, I want to see the sinus dipping properly. Then I would know how much length of the bone I have. Or if I'm placing a mandibular implant and I see that the inferoalveolar nerve passing is way too high, so again I have to limit my depth of implant. So when I say I want to check the quality and quantity of the bone, I want to see the most important relevant anatomic structure so that we don't have any complications. So the option of image resolution, breadth of coverage, linear measurements are all very secondary compared to the option of visibility of important anatomical structures, correct? But if my image resolution is not good, then will I be able to see anything? No. So that kind of also is a correct answer. Breadth of coverage. Well, it depends which area you want to cover. So if you're going to cover a small area, you can ask for a CBCT. So your prescription of the radiograph will determine the breadth of coverage. So again, that can be controlled. So it's not like it's out of control. Linear measurements, well, that is a very important. So yeah, linear measurements, that becomes my answer of choice. Why? Because have you taken a periapical radiograph? I'm sure you must have. Now, when you take a periapical radiograph, it can be either on a film or it can be digital. But the accuracy with which you can measure with the softwares available, the distance, with those radiographic, not radiographic, the scale, there is a tool called as a scale where if you measure the length and breadth, you can actually see how much bone is here and there. But periapical radiograph becomes like a 2D image. So you can't like change the angulation of it and can view. And the same holds true for OPG. So you can measure like in one plane or two plane maximum the measurements. But in CBCT, you can measure, you can rotate the scan, you can form a 3D image, everything. So when I am going to say that I'm prescribing a radiograph for you, the thing that I have in mind is that I want to check in 3D view, as in the length, breadth, and the width of the bone available for placing the implant. So that is what this question means. How I'm going to check the quality and the quantity of the bone. Now, sometimes, see, radiographs and OPG will show you the mesiodistal loss of the bone. It will never show you the facial and the lingual bone quality. But a CBCT will immediately show you exactly where you can place the implant, buccally or palatally. Mesiodistal you can determine by periapical and OPG. But buccolingual you cannot determine. You have to use a CBCT technique. So basically what this question is asking is which technique for placement of implant you would be using for radiographic purpose. But instead of that, they have given this elaborate question of how will you assess the quality and the quantity of the bone. So, what the CBCT has advantage over the above techniques is that you can do linear measurements. OPG and IOPA will also show you the visibility of the important anatomical structures. So, though this option looks like a very, tempted option that you should go for it, you're not understanding that what the question is asking. So, you need to read the question properly, that the question is actually asking you which radiographic technique is best for the implants if you want to check the quality and the quantity of the bone, and hence the answer becomes linear measurement or synonym pseudo CT. Understood? So let's go ahead. SBQ6. The patient is on antidepressant and they have even given the brand name Zoloft. He is divorced and is now fighting for child's custody, which means he's under a lot of stress. Plus, he's taking antidepressants. He is also having financial constraints and is planning to switch his antidepressants to some holistic approach as the current medication gives him bad reflux. And his life is being affected and impaired by it. The antidepressants have their own side effects, one of which is the acid reflux. You feel highly nauseated. So he wants to change it as it's affecting his life. He has bruxism and looking for missing teeth replacement. So he has bruxism, he has stress, he's on antidepressants, he's planning to change his medication, and he wants to have teeth replacement. So he asked you an advice about painkillers. What would your answer be? Now, this question is just basically on the scenario of the patient. Nowhere the question is mentioning that he's having pain somewhere. Okay. So in general, ADC wanted to ask you this question, keeping this scenario in mind. So what the question is also trying to tell you is that C is an antidepressant, so he might want to get another drug to just feel good. He may actually not be in a pain. So sometimes patients will come you just with a prescription of medication, citing that they have pain somewhere, but the pain won't match with the clinical conditions. So what the ADC wants to say is that would you give in and prescribe some medication just because the patient wants it, or would you do the ethical thing and not give him the medicine? Understand? So let's see the options. All pharmacological prescriptions for pain is prescribed by GP. No, you can't say that because you can prescribe painkillers. Just refer to GP. Technically not a wrong option, but let's see other options. Tell him pain is a very vast area and it may be caused by different reasons and send him to GP. Not a bad option again. Show him empathy, prescribe him only dental related solutions, and send him for medical referral for further medication. Now, this is a very comprehensive and right option. But if this option was not there, my option B and C are also correct. But because option D is given, I'm going to choose that. Like, you should always empathize with the patient. And see, sympathy and empathy are different. Empathize is trying to understand the situation. Sympathy is being like that, oh, so sorry, how can I help? You know, empathy is like, I understand your situation, so let me try find a solution for you. Like you respect the patient's solution, but you are not emotionally involved in it so that you don't go out of your way to do something which is wrong just because the patient wants it. You understand? So D becomes the right option. Which denture would you give him? Now see, whenever a question is asked like which denture would you give him, you always have to go with the best option. The best option is always cobalt chromium because it's more fixed, it's more retentive, it's like not so bulky, and you can have the taste and the temperature sensations from it because it's metallic. So that implant supported you can argue, but then it's so expensive and you as a general dentist won't be doing an implant. So at your level, which is the best option for the patient that you can do is cobalt chromium. Occlusal devices are often used to protect restorations and the natural dentation. Comparison of the effects of hard and soft occlusal devices on the nocturnal bruxism showed hard occlusal devices significantly reduced muscle activity. That's true. Soft occlusal devices were effective in reducing muscle activity. Not so much. There was no significant difference between the hard and the soft occlusal devices, and hard occlusal devices were not effective in reducing muscle activity. So option A and D are kind of contradictory. So you know that one of the option has to be correct. C, there is no significant cannot happen because there is a reason hard and soft devices exist. And A and B, either one can be correct. So even if you did not know the answer by elimination, you can come to option A by logic. All right. Which material is contraindicated to cleaning cobalt chromium? See, cobalt chromium is a metal, so you don't want to give something which has high acidity and which will cause effervescence or corrosion of the metal. Now, vinegar, you can argue, but if hypochlorite is given, then I will choose that option. If hypochlorite wasn't given, then uh, I could have also chosen vinegar or hydrogen peroxide. But I don't think so. They are entirely contraindicated. But hypochlorite is like too much effervescent and it will cause sudden corrosion because it's a very strong chemical. So hypochlorite becomes the answer of choice. Which analgesic cannot be given to him? Here, see, paracetamol is always the safest one. So you cannot say paracetamol cannot be given to him. Tramadol is a very strong painkiller which we usually don't prescribe. Oxycodone you can prescribe, but tramadol and oxycodone both come in the narcotic section. So if one cannot be given, other can also not be given. Now ibuprofen, why ibuprofen? See, ibuprofen is a non-steroidal anti-inflammatory drug, and one of its side effects is gastric upset. Now, patient is already having a gastric upset because he's taking antidepressant. So you don't want to add ibuprofen to it. You understand? So the only safest one that you should be giving is paracetamol. Tramadol and oxycodone, you should take GP's advice and then give. But at your level, what you can avoid is ibuprofen. SBQ 7, the last SBQ for today. A 60-year-old woman attended at the Department of Periodontics. So, you know, it's a perio question. Simple, right? With the chief complaint of an abnormal growth along the anterior border of her ill-fitting maxillary partial denture, which gradually grew in size over the past 6 months. Keyword gradually. The denture was fabricated about 2 years ago. The patient has been suffering from pain and discomfort during mastication for the past 3 months. That means since the swelling has started coming, she is having pain and discomfort only during mastication. The patient has not removed the denture for 6 months. Ouch. Painful and yuck. So much of oral debris and hygiene is horrible, that means. An intraoral examination revealed a fibrous mass which was polypoid, like multiple polyp kind of a thing which are joined together and has a soft consistency and a smooth texture. What is your provisional diagnosis? Now see, the question here, let's go back to the question. The question says that the patient is wearing denture for 6 months continuously. She's not removing it. So much of debris and oral hygiene, it's going to irritate the tissue. Plus, the site is also matching where chronic hyperplastic, fibrosis can take place in the maxillary denture area, which is most common. And then you have this mass of tissue right near the anterior border of the maxilla. It can be something else, but given the history of the denture fabricated like 2 years ago, not removed since past 6 months, and still the patient continues to wear it in spite of having pain and discomfort, it points to irritational fibroma. Minor salivary gland tumor. See, tumors are usually ulcerated, rough, and they can be smooth and polyploid like this, but the site, the location is not where a minor salivary gland is located. Benign mesenchymal tumors, leaf-like denture fibroma. This is not cauliflower leaf-like, so I won't go with that. Benign mesenchymal tumors, you can say, but again, they are connective tissue ones. They are not fibrous ones. Mesenchyme means a connective tissue, okay? Fibroma is a fibroma, which is firm. So this goes, everything is pointing towards irritational fibroma. The treatment plan consisted of both medical and surgical approaches. The treatment plan requires verbal and written consent, both of course. What treatment should be done here? So making a new denture is advisable, okay, because it's been 2 years and you don't know if the denture is fitting or not properly. But since the patient said there is pain and only during mastication and otherwise the denture fits well, so making a new denture is low on the list of my priority. Remove the denture and use nystatin. Nystatin is antifungal. This is not a fungal infection. This is like a physical obstruction in wearing the denture. So the right option here is excise the lump. So I understand if you're confused between make a new denture, but even to make a new denture, you need to get rid of that lump. So first step is excise the lump. Then see if the denture is fitting properly or not. If fitting properly, let them continue. If not, then you make a new denture. 7 days after surgery, that was the intraoral appearance. What will you do next? Uh, so apparently there is an image here which is missing, which I could not get it. So probably some other fibrous tissue would be there. Now, see, advise her to do implant instead is a wrong option because denture was fitting properly earlier, and nowhere the financial condition or the wish of the patient is mentioned. So you'll go with the basic thing as to make a denture. Now, if there was an image which showed that the denture was broken or something, you could have said modify the old denture or make a new denture or something like that. But if the surgical area of the picture showed that there was some fibroma left or something else which is not manageable by you, then you would be referring her to the prosthodontist. Hence, that becomes the correct answer here. So, depending on what the image is showing and what the question is asking, you should choose your option out here. See, gathering these questions is very difficult, like 280 questions after the exam and you don't get the exam paper anywhere. It's really, really difficult to gather the right kind of scenario, the questions and the sub questions. So wherever I can get the image, I can. Wherever I can't, then I just put the question like this. Now, important preventive part in this case is the type of denture she should choose or how to wash the denture and length of wearing the denture. Yeah. Clearly, the question mentioned that the patient has not removed the dentures in the past 6 months, which is like very poor oral hygiene. And if she continues to do the same thing again after excision of the lesion, then the same fibroma is going to come back here or somewhere else. So what needs to be taught to this patient is how to wash the denture and for how long she's supposed to use it. Like, not wear it at night, keep it in water, wash her mouth, wash the denture, oral hygiene measures and the denture hygiene measures. So the important preventive part in this case is this. Even if some other options were given, the anything else, this is what the question is trying to ask you, like how to prevent the same condition again. That is what the question is trying to ask you. So I hope this is clear and soon we'll record a session for the other questions. In the meanwhile, just go through this and yeah, analyze the questions and solve properly. Have a nice day, guys.